This presentation goes over toe walking in the pediatric population. The objectives for this presentation are to introduce you to what toe walking is and what you need to know as occupational speech and music therapists and different treatment options that physical therapists have, as well as tips and tricks for your practice. So what is toe walking? Well, toe walking, as one could guess, is when kids are walking on the balls of their feet or their toes. This is normal when a child is first learning to walk and usually occurs in the first 2 to 3 months of them walking, but is considered abnormal once they're over the age of 2 years old. There's 3 different causes for toe walking, which includes musculoskeletal, which could be due to a leg length discrepancy, neurological, which could be due to a sensory issue, or habitual, which is also called idiopathic toe walking, or a combination of these. So there's also some pathological conditions which are associated with toe walking, such as cerebral palsy, Sever's disease, peripheral neuropathy, and autism spectrum disorder, as well as different muscular dystrophies. For habitual toe walking, this is also called idiopathic toe walking, and it's usually when kids are walking on their toes out of habit, and this can run in families as well. What do you need to know as speech, music, and occupational therapists? First, you just need to be able to identify toe walkers, so be observant and watch them walk periodically. Toe walking has been reported with children with language delay and cognitive development delay, and in children with autism spectrum disorders. So it's important that you are able to identify and notice if a child is walking on their toes. And if you're unsure, you could always ask a physical therapist for a second opinion or another therapist that's around you. You could also ask the family if they've noticed any toe walking and see if they have a referral. And if not, you can offer to send an internal referral. There's also cases where kids can voluntarily walk heel to toe, and that is called idiopathic toe walking, and this is a diagnosis of exclusion. It's going to be really challenging to look at a kid and be able to identify what their cause for toe walking is, whether that's a leg length issue, a sensory issue, or due to an underlying pathology such as cerebral palsy. So that's why it could be ineffective to tell them to walk on their heels. So always just be aware and be cognitive of that. And if they have inserts in their shoes, make sure you keep their shoes on as much as possible when working with them. Next, I just want to do a quick overview of what range of motion is, since I'll be talking about it on the next couple of slides. So when a child's walking on their toes, they're in excessive plantar flexion, and their different treatment options will depend on how much dorsiflexion they're able to achieve. So what we're looking for is normal range of motion for dorsiflexion is anywhere from 0 to 20 degrees, but to walk, we need 10 degrees. There's a few different ways that range of motion can be taken at the ankle. So typically 3 or 4 different types of measurements will be taken to ensure accurate representation of the kid's available range. Next, I'll go over the different treatment options available for toe walking. So the primary options that physical therapists can offer is physical therapy, bracing, and night splinting. During the physical therapy evaluation, the therapist will determine what the likely cause is for the toe walking to determine if other providers need to be referred to. What the therapist can provide is a home exercise program that could involve stretching, backwards walking, or other types of exercises, and likely will be seen every week to monitor the toe walking. The therapist also can refer them for an orthotist to either prescribe bracing, such as ankle-foot orthosis, or a simple shoe insert, or for night splinting. And the night splint would be worn at night to increase the child's range over the course of weeks to months. And the ankle-foot orthosis or shoe insert would be worn in their shoes every time that they walk to provide either a tactile cue to their foot or the back of their ankle that they need to be walking on their heels and not on their toes. And the intervention selection really depends on each child and is decided on a case-by-case basis between the therapist and the family. There are other options for the more severe cases, which include serial casting, Botox injections, and then soft tissue surgery, which it usually is lengthening of the Achilles tendon. And these are also determined on a case-by-case basis, but require the child to be referred out to an orthopedic or neurologist. So as I previously mentioned, physical therapy will require an evaluation where the range of motion and tone is assessed. And then after the evaluation, the physical therapist will decide the appropriate referrals to make. And then there is an algorithm that is used or could be used for clinical decision making, which will come up in a couple of slides. And then, as I mentioned, for bracing, the braces would be worn daily in the shoes and could provide the tactile cue to tell the kid to get onto their heels versus onto their toes, but requires the child to tolerate wearing shoes. Another thing with the bracing is that the braces will only be effective if they are on. So that's why it's important for the kids with orthotics or braces to be wearing them during their therapies. For night splinting, this is the intervention that focuses on increasing the child's range of motion throughout their night when they're sleeping. So this also requires them to be able to tolerate wearing the night splints. So a kid with sensory issues may not tolerate this intervention. Serial casting is an option for the more severe cases where the child is lacking active dorsiflexion, typically less than or equal to 0 degrees. And with this intervention, the child would need to tolerate casting because they'll be recasted every week for the course of 4 to 6 weeks. And each week, the cast would be reapplied to increase their range of motion slowly over time. So this is a more challenging intervention just because the child would have to tolerate being casted. So a child with sensory issues may not tolerate this well, but this is an intervention that is done outside of the physical therapy clinic, and we would need to refer out for that. If the range of motion deficits are too severe, then surgery or Botox may be indicated, and this is typically a last resort, and the physical therapist would refer the patient back to their pediatrician or to orthopedics or neurology. So what physical therapists can do is use the Cincinnati Children's Evidence-Based Care Guideline for decision making, and this is good for new graduates that don't have the clinical experience yet to decide what they would like to do for their treatments for toe walking, and the following slides have those resources. This is just here for your reference. This is the screening algorithm that the physical therapist can use to determine if the child is appropriate for physical therapy intervention for toe walking or if they need to be referred out. This is another algorithm from the Cincinnati Children's document, and this one is used for determining the appropriate interventions. And this is the second part to the same algorithm, also helping guide a therapist through their decision making for what intervention the child would benefit most from. Again, this is just here for your reference, but if you decide you want to go follow through, it'll show you how the different ranges of motion that could be measured for dorsiflexion can guide the intervention. So tips for your practice. So as occupational, music, and speech therapists, it's important that you're able to identify toe walkers. So watch them when they're playing in the gym, when you're walking them back to their room, just look at their feet. Are they walking on their toes? How often? Do they have any of these other pathologies mentioned? It's important to be aware and make the appropriate referral if needed. It's important that you ask questions and refer if needed. So ask their caregiver, like, have they noticed toe walking? Are they concerned about it? How long has the child been walking on their toes? And use this as an opportunity just to educate them. In future slides, I will have a example script on how you can approach it if you're uncomfortable. It just really is about being honest with the parent and educating them on toe walking should not be occurring after the child's 2 years old, and that way they can understand that it is an abnormal thing and that it should be addressed. And you can also tell them if they would like it to get looked at by a physical therapist, that you can do the referral for them, and that way they don't have to worry about going back to their doctor. And this is really important that they get the toe walking addressed because it can lead to other impairments later on, and they could end up having increased falls, they could have balance deficits, they could end up with hip, knee, or ankle pain as they get older. So it's important that this is addressed when they're younger and as early as possible, because there is still time to make changes if needed, because what we want to avoid is contractures, which is when the joint is then unable to move out of that range. So it's really important that we are addressing the toe walking and giving the parents all the education that they need. Here is an example of the script I mentioned, and I just want to clarify that it's important that you don't tell the parent that it's abnormal, but you educate them that toe walking is developmental and should resolve by the age of 2. After that, they should consider referral to physical therapy. And by not saying that it's abnormal, it plants the seed in their brain that it's abnormal, and that way they can determine for themselves that it's something that they should get addressed. And the final tip is, if you're unsure if the child is a toe walker, ask the physical therapist for a second look. There's no harm in asking for a second opinion because we're all trained to look at different things. So, in summary, identify toe walkers when possible and make that appropriate referral because we want to prevent further issues from occurring as early as possible. Here's all of the references for this PowerPoint presentation, and thank you so much for listening.